Really honored to present to all of you tonight. As Rachel mentioned, I'm a breast medical oncologist, and I have the privilege of working really exclusively with individuals dealing with breast cancer. And I practice at the University of Washington and the Fred Hutchinson Cancer Center up in Seattle, Washington, and have been there now for several years and have the privilege of working with women, mostly women, not entirely, but mostly women dealing with breast cancer. And I'm also a clinical trialist, so I get the opportunity to be involved in the development of novel and new therapies for individuals dealing with breast cancer. Southwest Washington is also near and dear to my heart. I am a Washington native, and my parents still live in Kelso, where I grew up and attended Kelso High School. So great to reconnect with all of you in Southwest Washington and in Oregon. So thanks again for being here. I think I will, and as Rachel indicated, there's lots of material that I'm trying to cover for you this evening, but I would love to have your questions. I'm presenting this with some pretty technical material, but in my experience in working with our advocates and many of our patients, you all are incredibly well read and often ask harder questions than some of my colleagues. So I really hope that this will be open and available to you. And again, please pause me anywhere along the way with questions. So let's see. My goal here was to talk a little bit about new therapies in metastatic breast cancer. And I do report some disclosures. I receive research funding primarily to the University of Washington and Fred Hutch for the clinical trials that I'm involved in, and serve on a couple of advisory boards. So for this evening's talk, have a pretty broad area that I wanted to cover. I wanted to start with some quick statistics that you're likely all familiar with regard to advanced breast cancer, and then really try to do a highlight of some of the really exciting research and new clinical trial results that have been presented in the last year or so. And for these, I'm going to break breast cancer into kind of the various subtypes that we're all familiar with. So we'll start with updates in HER2 positive breast cancer, and then look at triple negative, some exciting data in ER positive, and then a couple of other topics that are close to my heart that we're involved in and research nationally and at the University of Washington and Fred Hutch. So that's kind of our overview for tonight. I'll just go ahead and get started. As you all, and we all are familiar, breast cancer is an incredibly common cancer. It's the most commonly diagnosed cancer in women in the United States, and is unfortunately still the second leading cause of cancer death. In 2021, we get statistics that estimate that there'll be about 43,000 women who will die of their breast cancer in 2001. We are making progress, but it's never, ever fast enough. We know that breast cancer accounts for up to 30% of all new cancers diagnosed in women, but fortunately, a much smaller percentage of those result in cancer death. And the vast majority of individuals diagnosed with breast cancer are going to live with this for many, many years and hopefully not develop recurrence. We also know that breast cancer is much more of a global health issue. It accounts for about 12% of all new cancer cases worldwide. And again, there are millions of women living with breast cancer. Let's see. Sorry, some technical issues here. The good news is that we are making a difference, and we are impacting the natural history of breast cancer, even in the advanced disease setting. So when we look way back since about 1990, the mortality from breast cancer is decreasing, but there's a couple really important messages here. First and foremost, these curves show that the rate of death is going down, but I would argue that these lines are not going down nearly as fast as we would hope or that they should. The other observation here is that this looks at both the incidence, the likelihood of developing breast cancer, as well as the likelihood of dying of breast cancer. And we see that these things aren't fair across racial and ethnic boundaries. And so although Black and white women have about an equal incidence of risk of developing breast cancer, we know that women of African American or Black descent are much more more likely to die of their breast cancer. And so there's just a tremendous amount of work that we need to do in terms of developing new therapies and helping make our treatments more equitable so that we can see better outcomes across all patients, regardless of their background. As a medical oncologist, so I'm the doctor that treats with the systemic therapies, we tend to think now about breast cancer as being a chronic disease. And it's something that we hope women can live with for decades and that we manage with a series of medications and supportive management. And so when we think about kind of the approach to treating advanced breast cancer, typically, this is defined, metastatic or stage 4 disease is defined as breast cancer that has spread beyond the confines of the breast and the regional nodes. So typically it's spread to distant sites. And we'll talk about bone, brain, and other organs, as well as soft tissues. Our standard approach is to do a biopsy and imaging to confirm the diagnosis and determine where the disease is involved. And biopsies have become incredibly important to help us define what type of breast cancer so that we can really tailor our therapies to get the best advantage and the best possible treatment. And now more and more, we're using additional more sophisticated biopsies to look at sequencing the genes in the tumor, as well as to use liquid biopsies to look for fragments of cancer in the bloodstream that can be useful to help us, optimize and personalize the therapy. We use systemic therapies as really the backbone of our treatment. And depending upon the type of breast cancer, these can include targeted agents such as anti-estrogens or hormonal therapies. These are things like aromatase inhibitors, fulvestrant, and others. And then a lot of our really important advances have come with targeted biologic agents. And these are things like trastuzumab or Herceptin, and more recently, drugs like palbociclib, Ibrance, ribociclib that target certain pathways that are critical for breast cancer. Chemotherapy, which are still essentially kind of a blunt tool, but chemotherapy or drugs that kill the cancer cells directly are still a really important part of our treatment. And then we also have supportive medicines like to help stabilize and prevent fractures or pain from bone metastasis. And then, one of the things that is really important in how we advance and make things better is the ability to do clinical trials, which allow us to investigate new agents that come from the scientific community to try to understand how we can do better to help women and men with breast cancer live longer and more full lives. There are additional supportive things that we do in terms of using radiation to potentially slow the cancer growth at a particular site. And those techniques of radiation are improving quite a lot as well. And then there's all of the supportive measures in terms of diet, physical therapy, massage, supportive measures, integrative medicine, and working with our colleagues in a lot of different arenas to help support individuals as they go through this journey with cancer. So I want to pivot and start to talk a little bit about some of this new research. I'm going to start with HER2 positive breast cancer. So this is a slide adapted from a colleague presented at one of our big breast cancer meetings, the San Antonio Breast Cancer Symposium back in 2021. And I show this just to highlight that the pace and acceleration in new drugs FDA approved for breast cancer has been incredibly exciting over the past several years. So if you focus here on the bottom of the slide, the metastatic breast cancer approvals, I've sort of listed all the different drugs that have been approved for HER2 positive breast cancer. And what I hope you can see is that just since 2019, we've had 4 new drugs approved or combinations of drugs approved to treat metastatic HER2 positive breast cancer. And so it's been a really pretty exciting time, and there's many more in the pipeline as well. And that is exciting and gives us hope, that we can continue to do better. So I wanted to start by focusing on a drug called trastuzumab deruxtecan. This is also we learned of it initially as DS8201 or TDXD. And this is a drug that has recently come onto the stage for HER2 positive breast cancer. And it's a class of drug that we call an antibody drug conjugate. And so what this means is that we take the antibody that is a designer protein that is trastuzumab that has really revolutionized HER2 positive breast cancer care, and attached to trastuzumab is a very potent chemotherapy agent. And in the setting of trastuzumab deruxtecan, it's what we call a topoisomerase inhibitor, which is a type of chemotherapy, and it's incredibly effective, but it's also too toxic to give by itself as regular chemotherapy. And so when we attach it to the trastuzumab or Herceptin, what that allows us to do is to deliver the chemotherapy more directly to the HER2 positive breast cancer cells. And so it's a much smarter and more elegant way of delivering treatment. So the Destiny-03 trial was presented initially in last year in 2021, and this has made a huge splash for HER2 positive breast cancer. And this is a trial that looked at the trastuzumab deruxtecan, which is shown in all these slides as TDXD. And it was a randomized trial, so patients who had metastatic HER2 positive breast cancer who had previously been treated with Herceptin and a taxane-based chemotherapy. All across the world, this was a global trial. Those patients who elected to participate were randomized by a flip of the coin to receive either the trastuzumab deruxtecan or to receive TDM1. And TDM1 is another antibody drug conjugate that has been our standard go-to agent because it's highly effective and is second-line therapy for this group of patient population. And so this is a large randomized trial. And I would point out that, again, you can see that there were about just over 260 patients in each arm of the study. And the majority of these patients actually were enrolled in other parts of the world. So the greatest majority of patients were actually enrolled in Asia, with a relatively smaller patient population in North America. And the study was designed to look at something called progression-free survival. And that means the time that's elapsed since patients started the drug in which their cancer is stable or improved. And so this is a common endpoint that we use for clinical trials. So I'm going to show you a bunch of these curves. These are called Kaplan-Meier curves, and these are how we look at clinical trials to compare how individuals do when they're assigned to one treatment or another. And so what we look at here is something called progression-free survival, which, as I mentioned, is the time from which a woman starts a drug, a new treatment, until the time at which the cancer starts to grow again. And typically that's detected by doing CT scans or some sort of imaging periodically. And so what we're always hoping to see is that progression-free survival is, we want to continue to see that number get higher and higher, because that means that the average, that the median time, or that the average time that a woman can stay on the drug and have their cancer be controlled is longer. And so this data was presented in about middle of 2021 and showed that those individuals who had received the TDXD or the trastuzumab deruxtecan, actually their disease, the time that their disease cancer remained controlled, was much longer than those who received our previous standard of care, which was TDM1. And so you can see these curves separate quickly, and the curve in the blue shows that patients who received the trastuzumab deruxtecan are enjoying a longer period of time where their cancer is under good control. So we also look in these clinical trials at different groups of patients to try to understand if the treatment may work better for some women and I'm going to say women a lot, and I apologize. There were a few men in this study, but for the most part, I always slip and often say women. But we also look at certain features of the patients. And so we want to know if patients with hormone receptor positive or negative breast cancer maybe do better or worse, whether prior treatment with things like Perjeta or pertuzumab make a difference. And so what you can see here is this shows that whether you look, regardless of the characteristics of the patient and the cancer when they enrolled in the study, there seemed to be a benefit for receiving the trastuzumab deruxtecan, as you can see with these purple dots, for patients with all these different clinical situations. So whether they had prior therapy, whether they had metastasis to organs like the liver or lungs, there seemed to be a benefit associated with receiving the trastuzumab deruxtecan. And so that's also very reassuring to tell us that the treatment is making a good impact. It's important that we always look at safety. And so safety is always important in these clinical trials to identify what the toxicities are. And for trastuzumab deruxtecan, what we can see is that we know that this still has chemotherapy with it. And so there is toxicity from this drug. And what we commonly see is more nausea, occasionally vomiting, and sometimes GI side effects. We also know that temporary hair loss is more frequent, but doesn't happen to everyone who receives TDXD. And so we always need to make sure that the therapy, even if it works better, we want to make sure that it's safe for patients. One of the unique features of this drug is that it can cause inflammation of the lungs, something called pneumonitis. And this was a concern in some of the early trials that evaluated this agent. And so they looked very carefully at this, at the risk of developing interstitial lung disease or pneumonitis across all the patients in this trial. And this is kind of reassuring data because it shows that the really severe pneumonitis that leads to disability or to death was not seen in this trial. And it didn't appear that women or individuals from particular parts of the world were more or less likely to develop pneumonitis. And so this is still something that we follow closely for our patients who are receiving trastuzumab deruxtecan and other medications. So one of the really most challenging parts of HER2 positive breast cancer is that it tends to have, HER2 positive breast cancer in particular, tends to have a predilection to spread to the brain. And our brain is much of a sanctuary site in that it's hard to get some of our treatments to penetrate through the blood-brain barrier. And brain metastasis can obviously be a really devastating and life-altering event. One of the really reassuring things that was presented just in December of last year about trastuzumab deruxtecan was that they looked at women enrolled in, or individuals that came onto the study who had either a history of brain metastasis that had been treated. And what they found was that the trastuzumab deruxtecan seemed to not only control the disease outside of the brain, but it also seemed to offer a really impressive benefit for women who had brain metastasis, meaning that the brain metastasis could shrink even while they were on the trastuzumab deruxtecan. And that degree of response was much greater than those women or those individuals who had received the TDM1. And so this is really very, very exciting data because it gives us a hint that this agent is effective not only for controlling the disease outside of the brain, but it could also be a really important therapeutic option for individuals with HER2 positive brain metastasis as well. And so the authors of this study concluded that trastuzumab deruxtecan showed a really consistent and an impressive benefit for both the time, what we call progression-free survival, over our existing standard of care, which has been TDM1. This doesn't mean TDM1 is a bad drug. It just means that now we have something even more powerful and more effective. And so based upon these results, we now have kind of a new standard of care. So trastuzumab deruxtecan has sort of moved up and is now the preferred agent that we use for individuals who have HER2 positive metastatic breast cancer who are receiving their second line of therapy. And this drug is now being evaluated in a whole bunch of additional clinical trials in different settings, including for early stage breast cancer as well. So the other super exciting agent in HER2 positive breast cancer is an oral agent called tucatinib. And tucatinib is what we call an oral tyrosine kinase inhibitor. And so it's an oral agent that also acts on the HER2 protein. And it's incredibly effective and is a small molecule. It's something that women can take at home by mouth. It doesn't require infusion. And there have been a series of these TKIs. The first was lapatinib, and tucatinib is a more potent and advanced form of this. And so we were really excited to participate in this trial called the HER2 CLIMB trial a few years back, and the results of this have now been presented and published. But this was a trial looking at the addition of tucatinib to an oral capecitabine, which is a type of chemotherapy, as well as Herceptin. And patients in this trial had more advanced HER2 positive disease, meaning that they had received 1 or 2 prior lines of therapy. And they, again, were randomized to receive the tucatinib. Let me back up. to receive tucatinib with capecitabine or a placebo with capecitabine and trastuzumab. Again, the capecitabine and trastuzumab were considered the standard of care for this patient population at the time. And what we found in the HER2 CLIMB trial is that in the overall population, by those individuals who received the tucatinib with trastuzumab and capecitabine had a risk, their progression-free survival was markedly improved compared to those who received just trastuzumab with capecitabine alone. And so again, we saw an improvement in progression-free survival. But the really, again, exciting part of this is that this trial in particular allowed individuals to enroll who had brain metastasis, and they didn't even necessarily need to be treated. And so this last December at our San Antonio Breast Cancer Symposium, the authors presented an update looking at the potential benefit of tucatinib for women with HER2 positive brain metastasis. And again, this is a little bit of a busy slide, but I'm showing you these survival curves. So this is the progression-free survival, meaning the likelihood of having cancer be controlled and doing well, that duration of time for women who entered the study with brain metastasis. And what you can see is that in those lighter blue lines, those individuals who received the tucatinib had a much longer period of doing well, meaning that their disease remained controlled for longer than those women who were receiving the placebo with just capecitabine and trastuzumab. And so what they saw was a 9.6-month improvement in the overall survival, meaning that women actually lived longer from receiving the tucatinib, as well as an improvement in the time at which the disease remained controlled. Sorry about my slides here. They keep wanting to move a little on their own. But again, this showed that there is the potential for drugs to really make a big impact for women with HER2 positive brain metastasis. And this is really a pretty remarkable change, because in the past, our main tool to treat brain metastasis has been radiation. And so it's really exciting to have treatment options, systemic treatment options that can control the disease in the brain as well. So this is a kind of a big summary slide, but now we have a number of tools in our tool chest. I talk to my patients about all the drugs that we have and think about it as, this is a long journey and we have lots of things that we can use to keep the cancer under control. And it's really exciting now to have new agents available in our tool chest to use if brain metastases do occur. And, ultimately we may want to consider using these things preemptively to try to prevent brain metastasis from occurring as well. But this just shows that tucatinib in the HER2 CLIMB trial showed benefit. We now have the trastuzumab deruxtecan. When that purple box that I just showed you, the data showed a substantial benefit, as well as we know TDM1 can have activity. That's Kadcyla as well. And so again, a lot of reasons for some optimism here in HER2 positive breast cancer. Finally, quickly here, I want to talk about the most difficult type of HER2 positive brain metastasis, which is called leptomeningeal disease. And that's when cancer involves the soft tissues that surround the brain and spinal cord. And sometimes we can even see cancer cells around the brain and in the CSF, or the cerebral spinal fluid. This is, again, a devastating and a really difficult diagnosis. It can cause tons of symptoms for patients and has uniformly been very, very difficult to treat. And so we were involved in a small study that looked at using the same regimen of tucatinib, trastuzumab, and capecitabine for patients who had leptomeningeal disease. And this is a report, again, from the San Antonio Breast Cancer Conference that showed that the treatment with this, and there was no randomization here, all the women got the treatment because there's really no standard of care, but showed that the women on this study had an overall survival of about 10 months. And I know that's not nearly long enough, but that's much improved compared to how women have done before. And so again, more studies to suggest that we're making some more meaningful impacts. So I will keep going here and talk a little bit about some advances in triple negative breast cancer. Triple negative breast cancer has been our most often our most difficult types or subtype of breast cancer to treat. It lacks that estrogen receptor or HER2, so it's been very difficult to target. And it's really just been in the last couple of years that we're making, I think, some really important steps to improve outcomes for patients with triple negative breast cancer. So I'm going to keep on the theme here of antibody drug conjugates. We saw this data back in 2020 at one of our European breast cancer conferences. But sacituzumab, this is also called Trodelvy, is what we call another antibody drug conjugate. So instead of the antibody being Herceptin, this is an antibody or a designer protein that binds to a protein on the cancer called TROP2. And TROP2 is a protein that's expressed on a lot of breast cancers and actually other types of cancers, including bladder cancer as well. And linked to this antibody is another chemo compound that is a very potent chemotherapeutic agent. It's a derivative of an older drug called irinotecan. And so this antibody drug conjugate was studied in the ASCENT trial. And this was a trial that had a similar design where women were randomized to receive either the new drug sacituzumab or to receive standard of care chemotherapy. And these are, I guess, again, an overview of the results, but this was one of the first studies to show that women who received, or individuals who received the sacituzumab actually lived longer and had a longer period of progression-free survival or disease control compared to our standard of care chemotherapy. And we have looked hard and long to find drugs that actually lead to a survival advantage for triple negative breast cancer, which can be really quite devastating in how rapidly it grows. And so this is, again, is a really important and an incredible advance for patients dealing with triple negative breast cancer. We always have to look at the toxicity, and because there's chemotherapy attached to this antibody, we do see issues with low blood counts, with neutropenia, and with nausea and diarrhea. And so we have to be really vigilant about monitoring for these monitoring for these side effects as well. But this was really a landmark study that showed that that this new compound can really make a big impact. And so sacituzumab or Trodelvy has now been FDA approved for women with advanced triple negative breast cancer. So I'm going to shift a little bit here to talk about the immune system, because the immune system is really important now in how we treat breast cancer. And it's been a long time coming to try to make us so that we can understand and utilize our body's own immune system to fight cancer. And this is something that's really near and dear to my heart, because I started out studying immunology way back, even during medical school and after. So our immune system, as you know, has become, we've all become rather immunologists during the COVID-19 pandemic, but we're learning a lot more about it. And so our immune system is really the way in which our body can identify toxins, and it can identify viruses and things in our body that shouldn't be there. And it's an incredibly elegant and well-controlled system to help clear bacteria, viruses, and hopefully cancer cells from our bodies as well. So the key components that you need to develop an immune response are the ability to recognize that a breast cancer cell shouldn't be there. And the way that the cancer cell can look different is by the fact that it acquires mutations that cause it to have different proteins. And it's really that ability for the body to see that the proteins in the cell are different that allow the immune system to potentially identify that that cancer cell shouldn't be there and to develop a really potent immune response. And so there are a number of features of cancer that we look at to help us determine how likely it is that the immune system can really help us fight the cancer. And that can include sort of things about how quickly the cancer cells are mutating or dividing, if there's an infiltrate of certain normal immune cells into the tumor, we look at that by something called stromal TILs. And then there are expression of certain proteins on the cancer cells itself that we now can interfere with that can actually make the immune system work better against cancer. So when we think about the immune system, it's a really delicate and a very elegant balance between wanting to control things that shouldn't be there, but also not having our immune systems go out of control to develop autoimmune problems. So we don't want the immune system to be too active because we don't want our own normal cells to be attacked. And so this is just a quick overview of some of the cancer fighting immune cells. We think about these as being cells we call CD8 positive T cells and CD4 positive T cells. And these are the cells that actually could kill a cancer cell, but they're very highly, tightly controlled so that they don't become, we want them to work, but we don't want them to work too much. And so we have this balance of cells in our immune system that are the cancer fighting cells, as well as the cells that are really trying to keep the immune system under check and probably help cancers actually grow. And those include cells like the T regulatory T cells, as well as macrophages. So one of the incredible advances for breast cancer, but really for all types of cancers, many solid tumors, has been the development and understanding of these proteins called immune checkpoints. And so essentially how this works is that one of the ways that a cancer can evade or hide from our immune system is that it expresses these proteins called PD-L1 which is programmed death ligand 1, but it's a protein that prevents the T cells from seeing that this is a cancer cell. And so it kind of is the brakes for our body's own immune system. And a few years back, there were really brilliant immunologists who understood this pathway, and they developed inhibitors, which are actually drugs like they're antibodies, so kind of like Herceptin, that bind to that PD-L1 protein. And these are called immune checkpoint inhibitors. And what these agents do is that they don't attack the cancer at all. But what they do is they take the brakes off of our body's natural immune system. So once that receptor, that PD-L1 receptor is blocked, it allows our body's own T cells to recognize that, hey, this is a cancer cell, it shouldn't be there, and to actually kill the cancer directly. And so these immune checkpoint inhibitors have been nothing short of revolutionary for a variety of types of cancer. They first made a splash with melanoma, with renal cell carcinoma, and now have really changed the landscape of lung cancer, as well as a number of other types of solid tumors. And so breast cancer, we're a little bit late to the party, but in triple negative breast cancer, we now have data to suggest that these immune checkpoint inhibitors could be really important for women, for individuals with advanced triple negative breast cancer as well. And so this is a trial called the Keynote 355 study that's looking at a drug called pembrolizumab. You can see ads for it on TV. It's called Keytruda, but it's one of these immune checkpoint inhibitors. And so in this study, individuals with metastatic triple negative breast cancer enrolled in a trial where they got the standard of care, which was chemotherapy, or pembrolizumab plus chemotherapy. And this trial was blinded in a way so that neither the patients or the physicians knew which drug they were receiving. And patients would stay on treatment, and they would have scans periodically to determine how well this treatment worked. And I'm showing you again more of these Kaplan-Meier curves, but what you can see here in the green line is that the individuals who received the pembrolizumab with chemotherapy had a longer period of disease control than those women who received, and then those individuals who received chemotherapy alone. And that this was a pretty substantial improvement in this progression-free survival. When we looked at different components of the actual cancer to see if we could identify which patients seem to benefit from this therapy. And what you can see here is that tumors, women with tumors that had higher expression of this PD-L1 seem to derive more benefit from the checkpoint inhibitor than those individuals who had tumors that didn't have as much of that PD-L1 expression. And so this was something that's important because as we add more drugs to treatment, we also add more side effects, and we want to make sure that we're doing our best to really optimize and to select the right treatment for the right patient at an individual level. So the way that we look for this PD-L1 is by doing a special type of test on a tumor biopsy, and this is called immunohistochemistry. It's an antibody test that's kind of the same way that we check for the estrogen receptor. And there are two different tests that are used to check for PD-L1. And the one that is now being used most commonly is the score called the combined positive score, which looks for the expression of that PD-L1 both on the tumor cells as well as on immune cells in the tumor. Like every test, there's some challenges with this, and I'm happy to answer questions about it, but there's really this is something that we're still trying to work out in terms of identifying really which patients are likely to benefit. But right now we tend to use the CPS score as our gold standard, because at least for right now, it seems to be that that's the key to telling us which patients are more likely to benefit from receiving the pembrolizumab. There's been another drug that you've heard about, atezolizumab, which was also approved for a period of time for triple negative breast cancer, but we couldn't see consistent results over it with additional studies. And so unfortunately, atezolizumab was FDA approved, and then the FDA approval was withdrawn, not because it wasn't necessarily effective, but that we couldn't show that it was consistently effective in repeated studies. So again, at our last big breast cancer meeting, the San Antonio symposium in December of 21, we saw an update from the Keynote 355 trial that really confirmed that those individuals who had tumors that had high PD-L1 expression were the most likely to benefit from the addition of the checkpoint inhibitor. And so this just breaks down the level of that PD-L1 expression according to the CPS score. And you can see that individuals who had the higher level of PD-L1 expression had the better outcome with the addition of pembrolizumab to chemotherapy. One of the other unique features of this trial is that they didn't mandate just one type of chemo. So they looked at different at Abraxane or nab-paclitaxel, regular paclitaxel, and other types of chemotherapy combinations. And again, this is really important for us, again, when we think about how we decide when we're talking with a patient, when we're sitting with you in the clinic, about which drugs and which regimen might be the best to use. And so we're making some progress. So this is just to kind of summarize. Immune checkpoint blockade in metastatic triple negative breast cancer is FDA approved now and is really changing the dynamic. We're still waiting to see on all of the results in terms of overall survival, but the findings that I've shown here are quite impressive, and we're hoping that this results in women living a much longer period of time. There's still a lot of questions, though, because we know that not all of these drugs work the same. So I mentioned atezolizumab, which was one of the first checkpoint inhibitors, which showed initial positive results, but then we couldn't replicate those. We also want to know what happens to patients after their cancer has become resistant to this therapy. What's the next best therapy? And how can we help them? And most importantly, how can we use our body's own immune system to really meaningfully attack cancer for other types of breast cancer beyond that triple negative type? And so there's a lot of work going on here. I'm going to pivot, unless there are questions, I'll keep going here and talk a little bit about ER positive metastatic breast cancer. So estrogen receptor positive breast cancer is the most common type. About 70% of all breast cancer diagnosed is ER positive. That means estrogen receptor positive, so sensitive and responsive to estrogen. And estrogen receptor positive breast cancer is often cured, but when it does come back, it sometimes can come back decades after original diagnosis. And ER positive breast cancer is one for which we have a lot of tools in our tool chest. And the preferred agents, the way we typically start when disease comes back, is to use anti-estrogen therapies. And that can include things like tamoxifen or aromatase inhibitors. Those are the drugs letrozole and anastrozole that we use in the curative setting as well. We now partner those anti-estrogen therapies with other targeted drugs, and those include drugs that interfere with cell cycle or interfere with certain components of the cell metabolism that have really changed and helped us improve outcomes for individuals who have advanced ER-positive breast cancer. This is a busy table, but the drugs that are called CDK4/6 inhibitors or cell cycle inhibitors have really changed and improved outcomes for women with HER2 positive, or with, for ER positive breast cancer, estrogen receptor positive breast cancer. And these drugs go by the name palbociclib, ribociclib, abemaciclib, and you may know them as Ibrance, Kiswali, and their brand names as well. But there's been a series of studies in advanced ER positive breast cancer that have shown that when you combine anti-estrogen therapy with the CDK4/6 inhibitor, you substantially improve that progression-free survival, and in some cases, even the overall survival. So individuals can live for a much longer period of time. And when you look at these table for progression-free survival, we're now measuring things in years. And so it's maybe that an individual stays on a therapy for an average of 2 years, but for some women that can be 3 years, 5 years. And so we're really talking about breast cancer, even when it's advanced, about being more of a chronic disease. Obviously, it's never long enough, but we are making some strides. So these drugs, the CDK4/6 inhibitors, have over the last 5 years or so have really, 5 to 10 years, have really become the gold standard for advanced ER positive breast cancer. We know, though, that these drugs don't work for everyone. And so there's a lot of interest in designing new types of endocrine or hormone-based medications to target that estrogen receptor. And this is a study that was also presented just recently in December of 21. This is called the EMERALD trial. And this is a drug that is a new type of anti-estrogen called elastrant. And what this is it's a drug that actually works a lot like fulvestrant or foslodex, in that it actually degrades or takes away the estrogen receptor from the breast cancer cells. And when the receptor is gone, then estrogen can't signal the cell and help it survive. And so it leads to cell death. One of the things that we know is that fulvestrant is a very effective drug. It also degrades that estrogen receptor, but it has to be given via an injection. And it's a pretty uncomfortable injection because it's several cc's of fluid into your gluteus muscle. And it's been difficult to dose fulvestrant to get the dose to be high enough. And so elastrant, this new drug, is an oral agent, and it allows us to give a higher dose of that estrogen receptor downgrader than what we can do with fulvestrant. So this is a trial called the EMERALD trial, and it was looked at women and men who had advanced ER positive, HER2 negative breast cancer, who had already received and for whom prior therapy with hormonally based therapies were ineffective. So they had experienced progression of disease. Patients could also have received 1 line of chemotherapy. And they, again, were randomized to receive this new drug, the oral elastrant, or they would receive endocrine therapy that was standard of care. And so that could be fulvestrant, anastrozole, lestrozole, or exemestane. And again, patients were followed to see how long how long their disease would remain controlled. What we call the endpoints here, we're looking at what that is, that progression-free survival, as well as looking at the progression-free survival in individuals who had developed a mutation or had acquired a mutation in that estrogen receptor called ESR1. And this is a table that just shows the characteristics of the patients who were involved enrolled in this trial. Most of them were women, but there were a few men. They looked and saw that many of the patients, about 70%, had disease metastasis involving visceral organs like lungs or liver. And the majority of patients had not received chemotherapy yet for advanced breast cancer, but about 20% had, but they were balanced. Again, showing you these kind of Kaplan-Meier curves. Here I would point to the curve, the yellowish curve, which is those patients who received the new oral SERD, that elastrant. And what it showed is that those individuals tended to have a longer period of disease control. And it reduced the risk of progression of disease or death by about 30% compared to standard of care endocrine therapy. And in those patients who had particular mutations of the estrogen receptor, the drug seemed to work even a little bit better. I would point out here that this is still these were individuals who had received prior therapy with drugs like Ibrance or palbociclib. And we still have a long way to go, because what you can see is that these curves kind of go down, meaning that patients are progressing or their disease is growing often at the first assessment. And so while the drug did help, it only really helped a small, it helped, but not as much as we would like it to do. And so we still have a lot of work to do, but this class of drug, this new oral agent, is very promising and is likely to be able to be another tool in our tool chest that could be much easier to tolerate than the injections from fulvestrant. So the authors of this study concluded that Elastrant was the first oral SERD, or selective estrogen receptor downgrader, to demonstrate a clinically meaningful improvement in progression-free survival in patients who had received prior therapy with the CDK4/6 inhibitors. It was well tolerated. I didn't show you all the safety data, but the side effects of this agent are pretty minimal. In fact, it may be a little bit easier than drugs like letrozole and anastrozole. We're still waiting for some of the results of this trial in terms of the overall survival. But I guess the point I would make here at the bottom is that this drug is one of many in this new class of oral SERDs and other estrogen receptor targeting drugs. And so there's amnestrant, there's a series of these very hard to pronounce new drugs that all kind of target that estrogen receptor and are coming online, and I think are going to be really important, again, to have more tools in our tool chest. And we're excited to be involved in some of these trials at University of Washington. Fred Hutch, my colleague, Dr. Linden, has really been instrumental in the development of amcenestrant. And one of my other colleagues is doing a lot of work with this new other drug called ARV-471. So it's fun to be able to offer these new therapies to our patients. So just going to do a quick time check here. Just a couple more really kind of quick topics. I wanted to talk a little bit about how we assess response to treatment, and particularly a special problem of breast cancer bone metastasis. So in the setting of advanced breast cancer, it's pretty common that we periodically do CT scans or MRIs to try to measure and assess what's happening to the metastatic disease, as well as asking our patients about the symptoms they're having and looking at their blood work. And so we typically rely on CT scans, which are really effective for seeing things like the size of nodules in the lung or the size of disease or nodules in the liver. Bone is special, though. Bone is actually the most common site for breast cancer to spread to, and this is particularly problematic for patients with hormone receptor positive or ER positive breast cancer. And bone metastasis, we can see them on scans like CTs, and we can also see them on bone scans. So we can make a diagnosis of breast cancer spread to the bone. The really hard part is that when you give a patient then a new therapy, it's very, very difficult with a CT and a bone scan, in fact, almost impossible, to know for sure if the cancer is actually shrinking once you give a new therapy. So CTs and bone scans are good at diagnosis, but they really fail us in the ability to know for sure if the treatment is working or not. And there's a large proportion of individuals with breast cancer metastasis who have disease only in the bone. So that's the only place that we can really assess. So this is an example. Our group and others at University of Washington and a number of other imaging centers around the country have really looked at how can we better assess what's happening in the bone. And so this is an example of some of the imaging that we use. And so bone scan, which is shown here in the panel A, has really been the gold standard for many years. But over the last 20 years or so, we've been using more of a technique called FDG PET CT. And what that does, it's a nuclear medicine test that actually measures the amount of glucose metabolism that's happening in the tumor. And so it's a much more direct measure of what's happening in the breast cancer. And PET is particularly good for looking for bone metastasis. So in panel B, you can see this is the same patient, and all of these little black dots that are going up and down the vertebral column here and in some of the other bones, those all represent sites of breast cancer spread. And when you look on a cross-sectional image, this is like a CT scan, when you combine the metabolic information, that glucose uptake, you can see these bright spots that show where the bone metastases occur. And so our group and others have looked to see if we use PET scans to monitor patients who are receiving new therapy. We showed data to suggest that changes in that PET scan could actually be better than using a CT to try to help us understand whether or not the treatment is actually working and benefiting the patient. And so a lot of years of work, but it led to a trial that we have open now through the cooperative groups. This is through a group called ECOG Akron, and it's called the Feature Trial. And essentially what we're doing with this study is to try to show whether or not PET scans could be useful to help us assess how women with metastatic breast cancer are responding to therapy. And this is again for patients who have bone dominant or bone only metastasis. And so we hypothesize that different categories of response will be predictive of outcomes, things like that progression-free survival, the time to develop a fracture or complication, as well as overall survival. And so this is a pretty simple study, but it's going on across the country, and I'm privileged to be one of the co-leaders. But it's a pretty pragmatic study where we're enrolling patients who are starting a new therapy for bone dominant metastatic breast cancer, and they get a PET scan at the beginning before they start therapy. And then we do another PET scan about 12 weeks later. And then we follow them and to see how long they remain, how long they do well on their therapy. And the goal here is to really validate and to be able to have criteria so that we can be very clear about knowing when a treatment is working or when it's not. And right now that's very difficult. And a lot of times women with bone disease, bone metastasis don't get to participate in these other clinical trials because it's not considered measurable. And we're really hopeful that this study will help us and allow more of those patients to be able to enroll in really cool new studies and to help us do better about understanding how their cancer is responding to treatment. So these are the objectives, and I would just point out, we're excited the study was open during the pandemic, but to date we've enrolled about half of the patients that we hope to accrue to the study. And this is is open in Portland at OHSU, as well as University of Washington and other sites around the country. And so again, a pretty exciting advance. I'm going to finish up here with something completely different. Everything I've talked to you about so far has been really things that are clinically really available to almost all patients in the clinic, or clinical trials for drugs that are becoming FDA approved. One of the other areas that I'm really excited about is, again, trying to use our body's own immune system to fight cancer. And what I'm going to talk about here in the last 5 minutes, this is not FDA approved. This is what we call first in human clinical trials. So we have a long way to go, but this is pretty exciting. So we talked about the immune system. One of the ways that we could actually make the immune system more effective is to actually take a patient's own T cells, those are the cells that fight cancer, and take them out of the patient, genetically modify them so that they become all programmed to do one thing, and that's to kill cancer. So we genetically modify those T cells, and then we give them back to the patient. And the goal here is that these T cells are now all revved up, activated, and genetically modified to go to the cancer cell and attack it based on the expression of certain proteins on the cancer. This was one of my mentors' silly drawings of how T cells work. And I only show that because, again, this has been a really novel way to fight cancer. And this type of therapy is now what we call CAR T cell therapy, because it's a chimeric, meaning it's a modified antigen receptor that is given to help kill cancer. And this type of therapy has really been revolutionary for patients with certain types of blood cancers, particularly lymphoma and leukemia, and now multiple myeloma. And there's a lot of us in the world who are really interested in how can we make this same technology work for breast cancer and other solid tumors. And so I'm not going to go through all the details here, but our research group at the Fred Hutchinson Cancer Center led by a scientist named Stan Riddell, an immunologist. We've really been interested in looking at this particular protein called ROR1 because it seems to be expressed very frequently on certain breast cancers, particularly triple negative, but it's not expressed on other normal tissues. And so the fact that it's got a selective expression on the tumor makes it a really attractive target for this type of CAR T cell therapy. So what we do is scientists design a T cell, a modified receptor that binds to that ROR1. And what that does is that it programs the T cell to go after the ROR1 that's expressed on the breast cancer. And we've been involved in this very first in human trial to evaluate how well these cells can attack and kill cancer in women with very advanced triple negative ROR1 positive breast cancer. And this is kind of a schema showing the clinical trial. As opposed to giving a chemo drug, we're actually giving the patient back their own genetically modified cells. And we start by giving them a low dose of the cells, and then we increase the cell dose and look at the safety and effectiveness of this therapy. And what we found is that we've treated about 20 patients with either lung cancer or triple negative breast cancer. And we've seen some hints that this therapy could be effective. It has not been a home run. And there's actually a lot of work still to do, because what we find is that the CAR T cells could be effective, but they get worn out quickly. So they get what we call exhausted. After we infuse them back into the patient, they work for a short period of time, but not quite long enough to make a meaningful impact. And so there's a lot of efforts to understand how we can make these CAR T cells work better. Again, this is really early data, and there's a lot of groups across the country that are interested in trying to make this work better. And I feel like this is something that we hope not in the immediate future, but down the road, what could be another really important way for us to fight breast cancer. So I have been talking for a really long time, and you've been super patient, but I will say that's kind of the topic list that I have for tonight. I appreciate it, and I want to just give a shout out. Thank you to the Pink Lemonade, to all the work that you're doing, to having that great support for your community, and for the kind invitation. I also always want to thank all of our patients and their families who participate in these trials. It's really through the generosity of all of you that are brave and willing to potentially be in a research study and to try new therapies. This is how we make advancements. And so I am exceedingly thankful to all of our patients and their families. And I also just mentioned my colleagues and our study teams and our colleagues in the immunotherapy clinic at the Fred Hutch as well. So I will pause here and maybe stop share. I hope